गुड इवनिंग।
Yeah, hi Dinesh, how are you? All good?
आई एम गुड सर, आप कैसे हो?
बस बढ़िया एकदम all good. And good
ऑल
evening to
गुड
you.
सर, ऑल गुड।
Okay,
Okay, sir.
good, good.
Okay, sir. We
Just
will be starting.
Yeah, yeah,
I will be giving you a countdown. Then we will
yeah.
start. Okay.
Right, right.
fine.
Three.
Joining us today is a genuine privilege and honor to welcome you all to the Bayer ISAT meeting. Today we conducting this meeting on DME and AMD. Our first topic is DME from understanding to treatment, and the speaker is Dr. Alok Agarwal sir. If I say about the training and education background, sir has done MBBS, MS, PhD, MF, RF, FSNEC, FACS from USA. Now, sir is attached with Sushruth Eye Foundation and Research Center. And our meeting second topic is ANMD, clinical information for clinician to enhance patient outcomes. And the speaker is Dr. Dinesh Shunta, sir. If I talk about the degree and training, sir has done MBBS, DNB, FBRS, and had many published papers on ophthalmology. And a very young, promising VR surgeon from Disha Eye Hospital. So now I hand over the session to our first speaker, Dr. Alok Agarwal sir. Thank you.
Yeah. Thank you, Mr. Abhishek, and thank you, Bayer, for inviting me for this session. Good evening, everyone. So I'll be starting my slides. Just give me 1 second. So, am I audible? Can you see, sir?
Yes, sir. It is coming, sir. Just give it. Now it's fine, sir. Now it's fine.
Yeah, one second.
Yeah. It's moving, sir. It's moving.
Yeah. Yes. So we all know, like diabetes, we are talking about diabetic macular edema. So we know, let us little bit just 2 lines about what is diabetes, and then we can proceed further. So diabetes is a chronic disease that occurs, either when the pancreas does not produce enough insulin, or when the body cannot effectively use the insulin it produces. So insulin is the hormone, that regulates the blood glucose. So hypoglycemia also is called a raised blood glucose level. Now, if you go with the different data, actually, now this data clearly shows the burden of the diabetes around the world. If you see North America, like 33% will be increase in 2045, and if you see Africa, with the current 19 million to 143% of the increase, like it's 47 million. So you can understand the awareness for the diabetes really has to be kicked off before everybody gets affected for the diabetes. So it's a really matter of concern for the world regarding diabetes. Now, what is the topic? Excuse me. So diabetic, I've given the topic for a little bit, speak about the diabetic macular edema. So we know why it occurs. So it's the presence of the excess fluid in the macular area of the retina, which when gets swelled because of the leaking of the proteins and the fluids, and causes swelling in the macula, and then the final outcome is the visual loss. So the pathophysiology for the diabetic macular edema is like VEGF-A plays a very important role. So how it increases? It increases the vascular permeability, and it disturbs the blood retinal barrier in the DME patients. So DME, like it can occur in both type of diabetes. It can occur in type 1 diabetes or type 2 patients diabetes, starting from mild to moderate to severe, visual loss. It's a leading cause for the blindness around the world, even in the developing countries also. So what are the challenges what a diabetic macular edema patient faces into the day-to-day life-changing consequences happens to them, starting from driving, near vision work, the difficulty in pursuing the colors, reading. Uh, Generally, these occurs in the working age group. So the visual loss reduces, the independence, productivity decreases, and the day-to-day ability to perform has a very drastic impact on the eye for patients having with DME. So if untreated, these diabetes can lead to severe visual impairment at any stage of the diabetes. Badly controlled diabetes or untreated diabetes, macular edema can lead to severe vision loss or even blindness also. You can see a cut section of the normal macula, even see the cut section of the macula with the diabetic macular edema. There's a color photo which clearly shows different patterns of macular aneurysm, succinate pattern of hard exudates, and all these retinal thickenings on with the patients with the diabetic macular edema. So again, the treatment for diabetic macular edema has changed, intensely since the time it is started. The gold standard treatment was from 1985 was the laser was the gold standard treatment. Now, then came in, ranibizumab in 2011. Then in 2012, it came to be fluocinolone acetonide, followed by the anti-VEGF was the gold standard now in 2014 when the aflibercept came actually. So again, a new drug which came in 2022 was faricimab. And again, in 2023, we can see there's a 8 milligram of aflibercept has come. So what are the key factors, the mechanism behind the pathogenesis of the diabetic macular edema? So if you see here, VEGF-A, which acts, VEGF-A is what, it's like a vascular endothelium growth factor receptor. VEGF is, I'm just giving the full form, it's a vascular endothelium growth factor. And then the PIGF is a placental growth factor. All these causes edema, inflammation leading to a neovascularization of in the diabetic macular edema. So what happens like when there is an impaired retinal blood flow, it causes hypoxia leading to the vascular leakage and edema. So the aflibercept, what it does, like it targets all the receptors. Even if the VEGF-A is completely blocked, the VEGF-B and the PIGF is still active and they bind to the receptors. That is why they contribute to the their pathological effects. The patient with the coming with the diabetic macular edema can see with just one dose of this is a recent patient which I gave an injection. Just with one dose of the Eylea, actually, you can see the significant reduce in the diabetic macular edema. To summarize, like VEGF-A and VEGF-B and PIGF are the key drivers regarding the pathogenesis of the diabetic macular edema. Aflibercept is the only globally available anti-VEGF agents that targets the multiple mediators of the retinal disease. So there are different studies actually which has been done, like they have the international guidelines. They teach us about the mode of actions, their own experience, the network meta-analysis, the real world experience, and definitely the randomized controlled trials. So it is very important to provide timely and effective treatment for all the patients with the DME and ensure that the vision gains are maintained in the long term. So there was a study actually with the Vivid Vista show what is the impact of the aflibercept in the diabetic macular edema. Now the the patient, like this study generally showed like the patient who received the very early intensive treatment with aflibercept had a very good visual acuity actually with a follow-up of 52 weeks. So what they achieved was like if you treat early, if you have an intensive treatment with the aflibercept, the vision gains were observed as early as when you give the very first injections. So patient received more than 8 injections throughout the year, and they maintain the vision starting from the initial loading dose. Across the 3 studies, patient treated with the aflibercept gained on an average of more than 10 letters. So at the week of 52 primary endpoints, it shows like the aflibercept was more superior than the laser in the Vivid Vista study. So again, delaying in the aflibercept treatment led to the poor visual outcomes, the data shows. So the international guidelines, which shows that the drug of choice in patient with best corrected visual acuity is less than 16 or 20/24 or worse. Again, different studies has been shown with the EURETINA guideline 2017. It showed like a drug of choice in the DME with baseline best corrected visual acuity 20/40 or worse. It showed superior to the bevacizumab over the 2 years and ranibizumab in the first year of the treatment. Asian study in 2018, worse visual acuity 612. Aflibercept was the result was more rapid visual improvement than ranibizumab over 1 year. Along with the difference was not statistically significant in the year 2 of the protocol T study. Then again, the third study was a diabetic Canadian study in 2018, which shows superior of aflibercept was noted in the group of participants with worse baseline visual acuity. This superiority of aflibercept at year 2 with gain of 18.1 letters in aflibercept, 13.3 letters in the bevacizumab, and 16.1 letters in the ranibizumab group of the 2 years. German study in 2019, it showed the evidence of the possible difference in the drug efficacy in patients with DME to the disadvantage of bevacizumab at the visual acuity of less than equal to 20/50. So this is another patient with a diabetic macular edema with just one injection. You can see a significant decrease in the edema. There's a little bit of subsensory RD is still there, and the patient is into the follow-up. To summarize with this one is like aflibercept can achieve a very visual good outcome with DME as demonstrated by the randomized control trials, meta-analysis, and international guidelines and recommendation given to them. That's the drug of choice. Patient getting treated with a baseline visual acuity of less than 69 letters or 20/40 or worse. It highlights the effectiveness of aflibercept in the clinic where patient regularly presents with a poor visual acuity less than 69 or 20/40 vision. So patient with visual impairment due to diabetic macular edema, particularly those with baseline 20/40 or worse, can achieve a meaningful visual gains with aflibercept compared with the other anti-VEGF in the real world clinical practice. So I think so that was the only presentation.
Yeah, thank you, sir. Thank you for a very insightful presentation. In the slide already there, we have the study which is claiming how effective it is for your day-to-day practice, and also you are sharing your 2 cases which also prove that what we are claiming that's proven by your data also. Thanks for a very insightful presentation. So
Thank you,
now
sir.
the forum is open for the audience and special for the Dinesh sir, if any kind of question from the audience side, or Dinesh sir, any kind of question or any suggestion from your side. Thank you.
Just one question just one question from the sir, that what is your drug of the choice in the case of the bad diabetic, just like if there is a recurrent DME or recalcitrant DME? What do you prefer in the
See, the
case?
thing is, like we'll just check the visual acuity to the patient. Like bad means for like you're talking about the PDR or what you're talking about?
I'm talking about the recalcitrant DME cases.
Okay, so the first drug of choice can be, depending upon the age of the patient and along with the clinical diagnosis which we do on our routine part. See, the first drug can be. I generally don't go with the the maximum doses with the patients. So starting with the ranibizumab, and then I go with the the aflibercept or Ozurdex or something like that. So depending upon the response to each and every patient, so becomes very difficult to say which patient responds which one. So clinical diagnosis is very, very important for me.
Thank you.
Thank you, sir. Thank you. Now the session is hand over to Dr. Dinesh sir for your presentation. Thank you, all of us.
Thank you.
Slides are visible.
Slide is loading, sir. Slide is loading. It is buffering, sir. Yeah, now it's perfect.
So good evening, everyone. So presentation today is what the clinician should know about neovascular AMD. Talking about the global prevalence of the AMD, we
Sir, your voice is breaking. Sir, your voice is
will
breaking.
be
Sir, you are not audible, sir. Your voice is breaking.
estimated the number of the people with AMD.
Yes. Sir, you are not audible, sir. Your voice is breaking. Dear audience, actually, Dr. Dinesh Gupta sir is facing some technical issue. He's rejoining. He's trying to sort out the technical issue.
Okay, okay.
এখন শোনা যাচ্ছে?
এখন তো ঠিক আছে।
Your slide is loading, sir. Your slide is loading.
একটু দাঁড়া। Yeah.
Sir, your voice is clear, but your slide is not coming, sir. It is loading. Hello. Hello. Sir, I am audible, Dinesh sir. Hello.
Yeah, Abhishek, you are audible, but we can't hear Dinesh sir. I think sir is facing some bandwidth issue.
Bandwidth issue. Hello, Dinesh sir. Hello. Now try to share your screen, sir. You are visible, sir.
Just stopping my video so that it will be better for us. Slide.
Your screen is coming, sir.
Hello.
It is loading. Yeah, it is loading, sir. It is loading. Yeah, it's come.
Okay, I'm just stopping the video so that it will be easy for us. Okay.
Okay, fine. Just do one thing, sir.
Okay.
Just is give
We
the
can
presentation mode. It is now now fine. Yeah. Fine,
Okay,
fine,
okay.
sir, fine.
So sorry for the disturbance. So
It's
it
okay,
is
sir.
estimated that the number of voice is okay, right?
Right, sir. Right.
Okay, thank you. Let me continue. So it is estimated that the number of the people with AMD is around 196 million, increasing to a projected 288 million in 2040. These estimates indicate the substantial global burden of AMD. So coming to the symptoms of the AMD, it is a blurring of the central vision, and very important, patient give the history of metamorphosia, that is the distortion of the images and the center straight lines, central scotoma, and a general haziness in the overall vision. And these symptoms of the AMD usually appear suddenly and it worsen rapidly. So initial visual symptoms are the blurring of the images, whereas in the later stages we can see that the blurring will become a central black shadow, central scotoma. So coming to the stages of the AMD, it is early, intermediate, and late. In the early stages, we find the initial drusen, small drusens. In the intermediate stages, it becomes larger and cause changes to central vision. Whereas in the late stages, we can see either it is dry atrophic, which is called a geographic atrophy, which we can see in the fundus picture, or the most dangerous one, that is a neovascular AMD, the most aggressive form, which can loss of the vision. So the diagnosis of the AMD is multifactorial. Mostly in our daily practice, we do with the help of the OCT, DFA, and ICG, and Opta is also very helpful, and the vision chart and also the AMSLR grid. So the management of the AMD, it is the dictum is that is the time lost is the vision loss. So reduce the treatment burden while maintaining the vision gain. So early diagnosis and early treatment is the main thumb rule. So coming to the factors which drive key mechanisms behind the pathogenesis of the neovascular AMD, VEGF-A and PIGF act via VEGF receptors to promote vascular leakage and edema and inflammation and neovascularization. So in this diagram here we can see there is a receptors of VEGF 1 and 2 and the factors. So VEGF-A acts via the VEGF-1 and 2 receptors, while the PIGF acts directly with the VEGF-1 receptor. So excessive activation of these receptors result in the leakage and inflammation and the edema. So what the aflibercept or the Eylea molecule does? It's a globally available anti-VEGF agent that targets multiple mediators of retinal disease compared to the other molecule. Whereas the other molecule block only VEGF-A, but aflibercept blocks all the three VEGF-A, VEGF-B, and PIGF. So these are the currently approval and anti-VEGF agents. We all know. I'm not going into detail, but the most important that is the Eylea, that means aflibercept, targets all the four ones. And most important, the half-life is comparatively more than all the other anti-VEGF agents. So it is we all know that Eylea is a choice of the anti-VEGF agent in wet AMD with the help of the RCTs and the real world experience. Coming one by one, the most important Altair study. So here we can see that it is a multi-center randomized open label phase 4 study in treatment naive patient with neovascular AMD. Total number of the patients were 247. I'm not going into so much detail, but the mean change in the base criteria visual from baseline and injection number at week 96, here we can see that there are two-week and 4-week treat and extend regimen. Here we can see that a change in the BCVA was 7.6 and the total number of injections required was 10.4. And the proportion of the patients at Q16 intervals means 4 monthly at the final visit was 41.5% in this treat and extend regimen, which is quite significant. Coming to the Altair study vision gain, which were achieved in year 1, that is at the 52 weeks, where it is near about 9.0, and this vision gain was maintained till the second year, means week 96, with hardly more than 4 injections in the year 2 in both the treatment groups. That is a 2-week and 4-week treatment adjustment. Here we can see that 9.0 primary endpoint at year 1 was maintained near about 7.6 till year 2 with hardly 4 injections. In Altair, up to 96.2% of the patients extended to Q16 maintained this interval to week 96 with aflibercept, which is quite a very significant because hardly any molecule can maintain this Q16 with such a number of percentage. Aflibercept can achieve vision gains that are maintained in the long term. What we require in our daily clinical practice, what we achieve this vision gain in the first year should be maintained throughout the life, or at least 4 years, 5 years, with low treatment burden, which you are getting with this molecule. So here we can see in the View 1 study, so till the 52 weeks, that is about near 1 year, the vision gain was 10.4 letters, which was maintained till 96 week, that is 10.2, and at the week 212, that is near about 4 years, here we can see that the vision was maintained 7.1. So vision gain was maintained for approximately 4 years with continued proactive dosing, that is treat and extend study as per study protocol. And also the study from the FRB registry showed that the treat and extend regimen achieved good visual acuity gain with a reduction in treatment burden in the second year. So change in BCVA from baseline, that is 61.4 letters, till 2 years, it has been maintained, that is around 67.4 letters. So mean number of the injection required over 2 years was 13.6. So these are all the randomized control trial I'm talking about, and later on we will come into the real world experience. And also the study from the Moorfield demonstrated that the vision gains achieved with aflibercept 2Q8 in year 1 were maintained in the long term to year 4 with continued proactive treat and extend dosing. Here we can see with the graph that at the year 1 the vision was 61.9, in the second year it is 61.8, in the third year it is 61.7, and the fourth year it is 60.4. So it is quite significant that this vision was maintained throughout the 4 year, and injection was hardly required in all these years. After the first year, it has been decreasing. The same study and also the same study by Jaggi et al. It is a different study in which they have started from the very beginning treat and extend, not given any initial loading dose, and also in this they are showing that the vision was maintained till the 4 years, that is 63.7 letters, which was achieved in 1 year, was maintained till 4th year, that is 58.5, with reduced treatment burden. That the median injection interval was 11 weeks, and the 35% of the patients met the exit criteria, and the therapy was terminated after 2.6 years, which is quite significant. So the real world patients with neovascular AMD can achieve outcomes which are comparable to those in RCT. So what in the RCT is the theory and what we are getting in the real world experience is a practical. So all this RCT done with this molecule V1, V2 and Altair, and the real world experience in the Moorfield and Jaggi et al. Are saying that is which is very comparable. So it is quite significant. So aflibercept is a choice of the anti-VEGF in PCV. Although not common globally, PCV, we all know that the PCV is more prevalent in the Asian population, near about 22 to 61.6%. And so that's why we are getting so much of neovascular AMD or PCV patients compared to Caucasian and South America, which is hardly 10 to 20%. And this is a very important study, PLANET study. We all know it has been compared aflibercept monotherapy versus aflibercept with the PDT, which is a quite famous, and it has been shown that after the initial monthly doses, we have made a two arms, that is aflibercept monotherapy and aflibercept with the quiet PDT, and the primary endpoint year 1 and year 2, it has been shown that hardly there is any change between the two arms. The aflibercept monotherapy resulted in the vision gains of more than 10 liters from the baseline at week 52. Here we can see it's quite important, and the mean number of the injections in the year 1 was hardly 8.1 in the monotherapy, and also in the with the aflibercept with the PDT it is 8.1. And here we can see that this change, this vision gain at the 1 year was maintained till the second year in the monotherapy arm. So in both of the treatment arms, more than 80% of the patients showed no evidence of active polyps, whether it is week 56 or 96. So if we compare the both arms, proportion of the patient with complete polyp regression, it is 39% compared to 44, and in the week 96, it is 34 compared to 30. And the proportion of the patients with no evidence of active polyps is quite comparable in both of the arms. So across clinical trials and clinical practice, proactive aflibercept monotherapy achieves clinically meaningful vision gains in patients with the PCV. All these real-world studies like Sato or Hosokawa are comparable with all these RCT, that is View 2 Apollo PLANET study. So complete polyp regression have been observed across clinical trials and real-world case series with aflibercept in PCV. So what we are trying to say that almost aflibercept monotherapy is quite possible to maintain the vision and also the polyp regression. So nowadays we also don't have any PDT. So aflibercept is the drug of the choice. And coming about the ocular safety, we all know that the Eylea, in also my clinical practice, I can easily say that Eylea is the safest drug among all those. If we compare with the faricimab and brolucizumab, faricimab is also quite better compared to brolucizumab. It has lots of the IOI near about, if compared to the 10,000 injection, near about vasculitis is 5.6 and vascular occlusion is 3.0, whereas in aflibercept it is hardly, almost nil. So aflibercept 2 milligram efficacy and safety profile has been established across RCT and is supported by over a decade of real-world PV monitoring, more than 20,000 patients, 20 countries, 9 million patients per year, 62 million doses, lots and lots with very hardly any AIO or any endophthalmitis. It is obviously the drug of the choice. Thank you.
Thank you, sir. Thank you for your wonderful presentation. How you shown your confidence, your on safety profile and efficacy of aflibercept. So thank you. Thank for your trust.
Very early from my fellowship days.
Yeah.
Very
thanks for your confidence.
Days,
so now the forum is open for the audience and also from Alok Agarwal sir. If any kind of question or any kind of suggestion from your side, sir, Alok sir.
Just what is the usual gap actually you give between the two injections for the AMD patients?
So if we start from the loading, actually, in our clinical practice for the first year, go with the PRM base, and if we see the patient is quietly maintained and doing good, then we convert the patient into T10X.
Sir, you can share off your video because your voice is breaking, sir. If you want, you can switch off.
Okay,
Yeah.
okay.
Okay. Your voice is breaking, sir. If you
So,
don't mind, you can.
so
repeat.
start with the loading dose. Start
Okay.
with the loading dose, sir. And for the 1 year, we do the PRN basis. And if we see the
Mhm.
patient is doing good and maintaining well, then after the first year,
Mhm.
we try to receive the patient into T10 extended.
Okay. Okay.
It's very good drug actually. I'm using
Yeah.
days, quite helpful, quite if no other any molecule is working, just give early, it will work
Mhm.
in all the diagnosis.
So we say like actually minimum 6 weeks to hold on for the second dose. So what do you say for that?
After the loading dose, sir,
Yeah.
sir, after the loading dose, we don't start. Usually, we don't start the patient with the treat and extend regimen. We continue with the PRN basis only. And
Okay.
after 1 year, we start with the treat extend plus 2 or minus 2 week. So
Okay.
usually most of the patients don't need injections near about 2 months or 3 months. Easily 2 months or 3 months gap is quite well maintained. Not an
Okay.
issue at all overall.
Hmm. Okay.
Abhishek.
Yeah, thank you, sir.
Yeah.
I think there is no question from the audience, and it is good to close. So once again, thanks for your valuable time for the benefit of the audience. Thanks,
Yes, sir.
sir. Thanks, Alok sir.
Thank you for inviting us all.
Yeah,
So thank you so
Thank
much.
you so much, sir. Thank you for joining us and thank you for your valuable time.
Yes, thank you.
Thank you,
And
sir.
thank you, Dinesh. Bye, Dinesh.
Thank you, sir.
Thank you, sir. Thank you, sir.
Yeah.
Bye. Take care. Thank you, sir. So can I close it now?
Yes, sir.
Can I leave the group?
Yeah, you can leave. You can leave, sir.
Yeah.
So now I am
Thank you.
requesting I am now requesting our tech team kindly log off this link so that you can discount it really.
Sure,
But-
sir.
Yeah. Thank you, sir. Thank you.
Yes.
Thank you for
Thank you.
valuable time, sir.
Take care. Bye.